So question number one is, what is the link to ITP, and could someone who has had ITP develop CLL? So it's normally the other way around. CLL patients are all at a slightly higher risk of developing these autoimmune complications. Remember, ITP is actually quite common out there, and I certainly don't want people listening today to think their daughter's got ITP, they're more likely to get CLL. Unfortunately, we know that anyone who has either autoimmune hemolytic anemia or probably ITP has a slightly higher lifetime risk of developing a B-cell lymphoproliferative disorder, whether that's CLL, low-grade lymphoma. But I don't think we gain anything by going into that. Does CLL mean you have a high chance of developing tumours of other organs? So unfortunately, the answer to that is yes. We know from a number of international data sets that it's not just treatment that induces these other tumours, that all epithelial cancers, so cancers of the gut, the kidneys and bladder have been put here, yes, they are unfortunately all a little more common in patients who have CLL, and it probably reflects immune surveillance of cancers, that all human beings are probably developing pre-cancers all the time, and our immune system just sweeps them away. And so CLL patients probably are just innately more prone to them. We certainly know that some treatments, particularly fludarabine, but probably also bendamustine, increase the incidence of skin cancers in particular.
I think the gentleman there has got a question.
Hello. You mentioned that you were dubious about the benefit of rituximab in combination with ibrutinib. I wondered, you mentioned in the Murano trial, venetoclax was used with rituximab. Do you have the same doubt about the benefit of rituximab with venetoclax?
So that's a really very, very good question. So when Ibrutinib came along, the B-cell receptor blockers, everyone assumed adding antibody would be better. And that's why there was this plethora of trials set up. And people were genuinely amazed that there was no improvement. There was a bit of improvement in mantle cell lymphoma, but not in CLL. And so people thought, well, are we going to see exactly the same with venetoclax? But we've seen absolutely the opposite with venetoclax, because venetoclax used on its own, about 20%, maybe pushing 30% of patients get these very deep remissions, undetectable MRD. But when rituximab is added, that's pushed up to 60%, even higher, 70%. So more than doubling the number of patients who get these very deep remissions. And one of the theories might be that rituximab, of course, works via a completely different mechanism, and maybe it's driving cells, trying to kill them towards apoptosis, and because they're working on these completely different pathways, they've ended up being amazingly synergistic. And the trial that I'm not allowed to talk about in any detail is obinutuzumab, so the better rituximab combined with venetoclax. And that may or may not show even more remarkable data.
Got a couple of, well, 3 questions all written down. If you want to take them, are you happy to? Can you read them?
Yeah, hang on. The worst thing is, since becoming 50 years old, my eyes have gone wrong. Okay, so this is quite a specific individual patient question. Should I talk to them afterwards about a very specific patient question?
Yes, potentially.
I'll just talk in general terms. It's about cytopenias and what is safe.
So whoever's given this in, go.
Is a question about neutrophils and what is safe. So it's a balance of individual risk. There are many people out there who run neutrophil counts of 0.5, 0.8, 1. Many patients with myelodysplasia who have a neutrophil count of 0.2, 0.3. Neutrophils, as they fall, increase your risk of getting infection and sepsis. When you've had chemotherapy, the mucosal linings of your gut, all the natural defense areas are damaged, broken down, and so bugs and things are more likely to creep in. So low neutrophils in the context of chemo are much worse than low neutrophils which are just there because of the way you are. But that doesn't mean you can be too gung-ho about it. And I think if you're running a chronic low neutrophil count, particularly if you're getting down towards 0.5, you do have to be aware that comes with a degree of risk that has to be followed quite closely.
Whoever gave this in about that.
Oh, hang on, we've got lots of others.
Can you hold the microphone a little closer?
Oh, sorry. Yeah. Next question. For a patient taking ibrutinib, when would you scan to see if the abdominal nodes have reduced? Routinely, how many months? What other factors would influence you? So, routine scanning in CLL. In the UK, we love CT scans. We book lots of CT scans, and my colleagues in radiology keep telling me, can you book fewer CT scans? And why do we do it? Because we like objective data. Our patients like objective data. The downsides of a lot of scanning is the radiation that's involved. And actually, if you have a patient who's well in clinic, do you really need to scan them? The International Working Group on CLL has actually been a bit stronger and said CTs are not routinely required in non-trial practice. In every trial, oh my goodness, we'll scan people every 3 months, but that's for other reasons. And so it is hard. I always say to a patient, if the patient really wants a scan, I'll book a scan. But if they had prominent lumps and you've treated with Ibrutinib and you can't feel them, then actually you don't really need a scan. And I think it's a mistake to say, are we going to scan patients every 6 months? I can already imagine how the consultation's going, and they're saying, well, how do you know my lymph nodes on the inside haven't grown? And I say, do you feel well? Your bloods look good. Do I really think they've grown? No. Okay, they might have grown half a millimetre or two. Do you want to actually find out and add an extra layer of stress? Whereas you could just walk out of here and say, Dr. Follows says I'm doing fine. And so we have that type of conversation. But anyway, that's CT scanning. If you are tested for IGVH at your diagnosis, can mutated become unmutated over time? So thank you, very good question that allows me to reinforce that point, that the IGVH, your immunoglobulin mutation status, is a set state for your disease. That's what it is. It can't change. And that's not to confuse that with the 17p deletion, the 13q, the 11q, and also the mutational status of TP53. Those can all change, and they can change with lines of therapy. And depending on what therapy you've had, they might actually push more change, but that's a separate topic. But mutated, unmutated immunoglobulin change is how you are. So the question is asking about MRD and Ibrutinib. So a very quick thing, not everyone in the audience will be completely familiar with MRD, so I'll just remind people what that is. So minimal residual disease that we've always called MRD negative, there's been now an international consensus to try and change that to undetectable MRD. So you'll be aware that MRD negative, that means little u MRD. MRD is when you simply can't find the disease with your best technology available. In lymphoma, that might be PET CT scanning. In CLL, the best technology is probably doing a bone marrow aspirate, the dreaded bone marrow, and putting it through this multicolour flow cytometry, or even next generation sequencing that's in there, multiple thousands of sequence reads looking for CLL. And using those techniques, you can hunt right down to 1 in a, 10 to the minus 5, 10 to the minus 6, really in a very, very low level. And so treatments that can push you into a deep MRD consistently in all of the blood cancers translate into longer remissions. And it's not a great genius to think that, well, if you've got very sensitive disease, you go very deep and it might take 10, 20 years to relapse from it. But your question was about Ibrutinib. And Ibrutinib does not really induce MRD negative remissions. I'm saying that carefully because when I last had the opportunity to sit with John Bird, who's this major name from the States, and who they have the longest, in the Ohio State, the longest experience with Ibrutinib, he says clearly a small percentage of Ibrutinib patients who have been on long term have actually cleared MRD, apparently cleared down to undetectable MRD in their marrow. But it's not normally a disease drug that does that. And normally Ibrutinib works, the concept is you're taking it, the levels, some of you may know this, as you take Ibrutinib, your lymph nodes shrink and the levels in the blood go up. And those first apocryphal tale of the first 2 patients who stopped because their levels went up and the clinical trialists thought, oh my goodness, we're making it worse. And it was the 3rd patient who said, but hang on, all my lumps have gone and I feel great, can I not carry on? Because it recirculates the CLL. So it goes into the blood, up go your counts, and then the counts drift down. It might take a year or 2 for the counts to go normal. But normally with an Ibrutinib patient, if you did a marrow at a year, 2 years, 3 years, you still find CLL. But if the patient's walking around feeling well, playing golf, doing all they want to do, then does that matter? So you remember when I said watch and wait remains the standard because you can't cure CLL, so why intervene with the drug that potentially have side effects? So the basic principle Any drug has side effects, so if you have a well patient, well intervene. Now, what are the catches with that statement? I often ruminate over this one because we know we follow patients with CLL and we watch their immune system gradually fail. Not catastrophically for most patients, but you see that. And we've got good data, nice Birmingham data, looking at stage A CLL patients showing against age-matched controls, they have a much higher chance of being admitted to hospital with pneumonia over a 5-year period because of this failure of the immune system. And so, and also, you then intervene with FCR and things that really pummel the immune system. We know people who stay in a long remission after FCR, they can get rebuilding their immune networks. We see that with Ibrutinib, that after people have been on it a long time, they start to restructure their T-cell network, so their immune system starts to improve. But it always plays in my mind about exactly that question, that if you took a watch and wait patient, maybe not with a lymphocyte count of 6, but if you have someone with a lymphocyte count of 30 who's well, maybe their immunoglobulin levels are a bit low. Maybe these patients, if you intervened with a drug that didn't have much in the way of the side effects to try and clear the CLL, would they then reconstitute their immune system and have a better quality of life over the next however many years? And that is a very good trial question. The difficulty when you're running trials, so the Germans are running their high-risk CLL trial, which is intervening and randomizing to Ibrutinib and watch and wait. And we do have to see that data that pans out. But, you know, if you look at the Ibrutinib trial data, if you said there's a 1% chance of a fatal bleed, or there's an X% chance of a fatal ventricular arrhythmia, that X could be tiny, it could be 0.01. But if you have a well person and you've given them a medication and they died of a toxicity, that would be a disaster. And I think that's the problem that stalks the watch and wait trials. Yeah, and another extremely good question, and that provides us with a lot of challenge because, as we know, human beings age. CLL patients often have chest problems. The incidence of diabetes is common in the population. Cardiac problems, hypertension, everything can intervene. And the other thing is the dreaded lethargy can be caused by many of these things. It can be caused by being on a beta blocker. Some people get problems with statins, all these things which are everyday problems in the clinic, and you're absolutely right. And sometimes you simply don't know until you've treated a patient. Normally, CLL moves relatively slowly, and you can have a lot of counsel discussion with patients. And as I always say in my CLL clinic, and I think those of you who know me from the clinic would get that message, that decision-making is normally a balanced decision-making. It's rare that you have to dive in and decide you're going to intervene. But you're absolutely right. There's no escaping the fact that patients might come with 4, 5, 6, 7 conditions. And I guess slightly soft answer is to say, well, you build experience through the clinic and how you treat, but you're absolutely right. You don't really know with that individual until you treat the CLL as whether they feel better or not, and they might simply not feel better. Another wonderfully challenging question. So I've had everything from can it be explaining my twitchy eye? And I've said, I don't know. I'm always very diplomatic in the clinic. I say, oh, possibly. You're right. It can do strange things. It can do, CLL definitely things it can do, odd skin rashes. It's an immune disturbance. I had one patient who the poor cat had been kicked out of the house at the end because it was definitely fleas and it had had everything done to it because of these strange blistering things. Bone pain. Occasionally patients can present with bone pain. You're not meant to with CLL typically, but occasionally that can happen. The standard, the night sweats, the fevers, these things are a bit every day, but there are odd things around the edges, and sometimes you don't know until you've treated the patient, and then they come back and they feed back to you. But if the twitchy eye is still there after 3 months of Ibrutinib and all the lumps have gone, it probably wasn't CLL. So what you're saying is, have we created in a digestible, understandable, readable format information that will equip patients adequately for their first clinic visit? And I think the CLL Support Association addresses that well. They put these talks online. I think they can be accessed in due course. I think you are actually coming to the crux of the point that CLL has actually become quite complicated. And without a biology degree, you can sit there going, oh my goodness, what's this all about? And that's also one of the complications out there in the world of haematology, because if you're not managing CLL, you can be a consultant haematologist with a big portfolio of acute leukemia, myeloma, but not actually be so up to speed with all of the subtleties and the trials, and that is just a reality. I really support the educated patient bit. I celebrate when someone comes in and says, look, I really don't want to sound bad, but I've done this reading. And I go, great, because it means you can actually start your conversation at one level higher. And you and I both know that individuals are so different. Some people simply want it, whatever you say, doc, but for other people, that's just not how they cope with challenging life situations. And we've seen a big change in the last 5-10 years in health practice in the UK. People are really engaging with this whole thing about actually understanding, making choices. And you've just seen, I finished off that talk by saying in relapsed CLL, in the NHS, both Ibrutinib and venetoclax-rituximab are commissioned. They are both very different therapies. And actually, it probably needs a really good exploration with each individual patient to work that out. So the patient that comes into clinic knowing loads is a great start. It's a good position to be in.